would like to welcome you to the TMLT webinar series, How to Fight the Opioid Epidemic. Our presenter today is Brett Rowe. Brett is an attorney with Evans, Rowe, and Holbrook in San Antonio and has represented many physicians in both Texas Medical Board complaints and lawsuits. And we thank you for your time today, Brett.
Certainly.
Brett, the hosts or the planners of the event have no commercial affiliations to disclose for this talk. So this is going to be a very fast-paced event, or fast-paced webinar. Brett's going to cover a lot of territory in 30 minutes. We would invite you to stay on after the 30 minutes to ask questions if you have any at that time. So Brett, let's start with, what issues do physicians face when managing pain and opioid abuse?
Well, everybody who has read the news or seen it on TV knows that we have a problem. So I remember back when pain was the fifth vital sign, and it was something that everybody needed to take care of. Now we have the opioid epidemic, so we are worried about how do we adequately treat people in this time where there's an epidemic. And I know that some of you all are afraid to prescribe opioids, even in the right situation. So we're going to talk about that. I also want to talk a little bit about tapering opioids, about whether that's necessary, whether you have to do that or not. And I'm going to talk a little bit about patients who switch to illegal drugs because they can't get opioids from physicians anymore. And I'm going to start. I'm in charge now, right, Kathy? I'm in charge. So let's talk about the problem. I broke it down into how many board-certified pain management specialists do we have. And in 2018, there were about 2,300 ABPM board-certified pain specialists and about 6,600 ABMS pain management certified physicians. Problem is that we have 20 million Americans who have chronic pain that is so severe it affects their ADLs. Not just people with some chronic pain, but with chronic pain that affects ADLs. That means, if you do the math, that there's one certified pain management physician for about every 3,000 patients who have significant pain management issues that deal with their ADLs. So that is impossible for those pain management physicians to take care of all those people. So that's why primary care physicians are now tasked with assisting in that. I did some research on how do people get their pain medications, and a lot of people thought that it was, well, they buy them from drug dealers. It's actually the smallest percentage there. Most of the time it's their own prescriptions from physicians, or they get it from family members or friends, or they even buy it from family and friends. Drug dealers were by far the lowest in terms of percentages of where people get them. I've got a quick little story about a physician who prescribed hydrocodone. It includes acetaminophen with Vicodin. And this rheumatologist had to take care of a patient who had excruciating pain. Unfortunately, she decided to pick up her prescription and go to Houston and spend the weekend in a hotel and take most of the medications they had. She ended up passing away, mostly from the acetaminophen toxicity. And fortunately, we had an EMS driver that got the pill bottle, also counted the number of pills, so we were able to show that she overdosed herself. But these are one of the things that we're seeing is patients who are not complying with the orders of physicians. So at the end of the presentation, I'm going to talk about people who are drug seekers, who actually abuse the medications that we give. More of the problem, let's talk about nationwide. There were 22% fewer opioid prescriptions filled in 2017 than 2013. So we are actually making a dent. So that has gone down. However, opioid overdoses have increased from 8 per 100,000 to 13 in the span of 2013 to 2017. And fentanyl overdoses are probably the worst that we're having now. That jumped from 1 death per 100,000 to more than 6 per 100,000 because patients are now, or people are now trying to find ways to get fentanyl, and obviously it's much more potent. What is the advice?
So how do you recommend that physicians manage these complex patients?
One simple word is don't. When you have patients that are overly complex, you should not take care of them. You need to send them to somebody else that can. Don't go beyond your comfort level. Everybody has a different level to which they will take care of somebody's pain. And if it's overly complex, you need to probably switch those people over to a pain management specialist so they can monitor them. That's what their job is. They do it more often than usual family practitioners or internists. So if you have an overly complex patient, please send them over to pain management. And if you do send them to pain management, don't continue to treat them because some patients will try to get their pain meds from multiple physicians, and you certainly don't want to do that. Let's talk about the laws that apply. For every case where you prescribe pain medication, documentation is so important. Documentation is what I use if you were sued in a medical malpractice case or if you're brought before the Texas Medical Board. And we are obviously seeing more board complaints now because it's harder to sue physicians with the cap. Some attorneys don't think it's worthwhile. So documentation is what I have to use. So more documentation is usually better. And it's best practice for documenting if you use the CDC recommendations. And I think Kathy has a link there, or there's a link in the downloaded files that you can look at all of those. I'm basically going to go over those. This presentation is condensed into 30 minutes. I usually take 2 hours to give this, so I'm not going to go through everything. I'm going to try to combine it all. But basically, the CDC has recommendations and the state has rules. So I'm trying to combine all of those so that you can see them. Talking about managing patients that are challenging when they're on hospice or they're homebound. I'm going to talk about how we can best manage patients like that and what patients do have to, or you have to go to the PMP to check them out, and those that you don't have to. And prescribing Mobic is not the issue. The PMP has a list of drugs that you have to review the patient's records on. So you're entitled to keep them on other prescription medications, but the pain medications need to be prescribed by the pain management physician. In other words, you don't want to have 2 physicians writing the same prescriptions. If you're writing different prescriptions, that's not too much of a problem. All right. Let's talk about the PMP. I assume everybody is already signed up for the PMP. If not, there's the account information on the right there. The PMP you have to use for opioids, benzos, barbiturates, and carisoprodol. So all of those things are the things that you need to actually look up. It is not for take-home use. They've actually clarified that when this first came out. I constantly had questions about, well, what happens if it's in a surgery center? Do I have to contact the PMP if they're in the hospital? No, the PMP is designed to monitor patients who are self-administering. So if it's a take-home medication, you give them a prescription, that's when you have to monitor the PMP. It's not in the hospital or an ambulatory surgery center. Because you have a nurse or somebody giving them the medication, so it's not self-administered. So anytime that you give them that prescription, that's when you have to monitor the PMP. So when they're discharged from an inpatient setting, such as a hospital admission or an ER visit, that's when you have to check the PMP, but not while they're in that institution. When is it not required? It is not required while they're in the hospital, in the outpatient setting, in the ER, or an ambulatory surgery center. It is to monitor self-administration. And you don't have to check the PMP for hospice care? That was one of the questions that was asked. Treatment of cancer, treatment for sickle cell disease. Those are the things that I guess we are not so concerned about them taking pain medicine because we're not as worried about them becoming addicted in hospice care because they're going to pass. Treatment of cancer because it's so significant, and the same for sickle cell disease. There's also a rule about not checking the PMP if you document a good faith attempt to comply but are unable to access the PMP because of circumstances beyond your control. That's the computer doesn't work issue, just like I had at the beginning here when my computer did not want to turn my video on. If you make a good faith attempt to access the PMP, but for some reason it's just not going to let you do that, you can document that you tried to check the PMP and that will be sufficient. However, my recommendation to you would be you probably need to go ahead and try to access the PMP as soon as you can, later that day, the next day, and not just leave it alone. That would probably be the best thing to do besides just having tried to access it. Nursing home patients, if the patients are getting the medications from the nurses, then you don't have to access the PMP because you have a nurse giving them. Remember, it's self-administration. Let's see. Lots of questions. I may have to take some of these at the end because we're starting to get a whole lot of them. And they will answer about whether you can get CME for this. Otherwise, you get to sit through my 2-hour one. All right. This one's kind of light. Let's see. All right. Talking about review of the PMP history. I can kind of see it. We're okay. You need to document that history in the record. Some EMRs, I know we've got all sorts of different people on this webinar. Some EMRs will actually do that for you, but you need to have some kind of documentation. The PMP needs to be checked by either you or a delegate. I would recommend that you have your staff get their own numbers so that they can do this. You can't possibly check the PMP for every single person or every single patient, so you're going to need to have your staff members get their own information, login information. The query allows you to search 3 years in other states. If you think that a patient has come from another state, it's probably a good idea to access those other states just so that you get a better picture of how patients are doing. And like I said, they do need to set up their own accounts if they're going to be checking the PMP. Kathy? And I can't hear you.
Sorry. The rules about when physicians need to check the PMP in Texas are clear, but there are other issues, aren't there, with checking the PMP?
There's always ancillary issues to be concerned about, things that you may not have thought about, but we as lawyers always think about. Let's see, is this going to advance? There we go. You can't have your staff misuse the PMP. You can only query your own patient. That seems pretty obvious, but they have already had cases where people are looking up celebrities, their exes, somebody they want to blackmail. There are people that are doing that, and you will get in trouble because it is accessing HIPAA information, and that's why you want to have your staff get their own login information, because that way it's not you. You will probably still end up getting a call from the TMB because your staff has done it, but at least it won't be you. They won't be using your number to access this information. So get them their own login information and remind them that they should not be accessing anybody besides the patients that they really need to look at. Complying with PMP requirements, don't ignore the law because the TMB is watching. They get a list of pharmacy dispensed drugs, and then they compare that to a list they get from who queried the PMP. In other words, if a pharmacy gave out a drug that's on the list, on the PMP list, and then they can't find the concomitant query where you went to the PMP to check before you gave that drug, then they're going to say that you didn't query the PMP, and then you're going to end up getting in trouble. So it's very easy for them to check, are you doing that? The TMB can access either your information or they can even access the patient's information. So they can get a history of who you're giving them to, and they can get a history of how many or where the patient is getting all of their information. The TMB also compiles a list of what they call the top 50. And you don't want to make that list unless you are a pain management clinic. This is not automatically a problem, but you're going to have a legitimate need to be being one of those people that prescribe the most hydrocodone in the state. They can initiate a complaint on their own if they get this kind of information. Now, there's also pharmacy. People always ask me, well, what does the Board of Pharmacy have to do with this? Well, they notify the TMB of what they call 555 patients. In other words, patients who have 5 or more PMP prescriptions, 5 or more prescribers gave them to them, and they got them from 5 or more pharmacies. If you have have 3 patients that make the 555 list, the TMB can investigate. That's something you should be picking up anyway. If you are going through the PMP, you're going to see if other prescribers are giving the same medication, and you shouldn't continue that. So hopefully you will never be on this or have 3 555 patients, but if you do, the TMB will investigate. So this is another reason that you ought to be going ahead and checking the PMP. Now, Kathy talked earlier at the beginning of the presentation, this is not about pain management clinic rules. There's a whole special rule for that. It'd take me at least another hour to go through all of that. So that's not what we're going to talk about. This is more for general practitioners, internists, family practitioners that are prescribing chronic pain medication. If you prescribe medications that have to be queried in the PMP to more than 50% of your patients, you may be considered a pain management clinic. And so we are not going to talk about that. But?
So the TMB pain management is a separate rule from the pain clinic rule. Who does it apply to?
So, Board Rule 170, unlike the prior rule for the pain management clinics, applies to all physicians. So anybody who treats pain has to comply with Board Rule 170. The purpose is to protect the public and give guidance to physicians. So documentation is again important. If you're taking care of a chronic pain patient, these are things that are self-evident, but the medical record must document an H&P, including nature and intensity of the pain, current previous treatments for the pain, underlying disease processes, effect of pain on their physical and psychological function, history of abuse, presence of one or more recognized indications for why you're going to prescribe the drug. These are the things that you would always do, but if you end up having a TMB complaint, they're going to go through the rule and compare your EMR record with what is in this rule about all the things that are supposed to be documented. You're also supposed to have a treatment plan that's in writing, and that has to include how does the medication relate to this presenting complaint of chronic pain. The dosage and frequency, obviously you're going to write down. What testing or evaluations are you going to order if medically indicated? What other treatments are planned or that you even considered? And periodic reviews of this plan and objectives that will be used to determine success, such as did the medication relieve the pain and did it improve physical and psychosocial function? In other words, they don't want you just to prescribe a medication and then not look back on whether things need to be changed. So you need to make sure that it's actually doing something. All right, is this going to move? There we go. Informed consent. Now, when you give a controlled substance, you must give informed consent. That needs to be documented by either writing or something added contemporaneous to the notes. Oftentimes, I see Risks and benefits discussed, that's sufficient. It's usually better to write more, but if you wrote risks and benefits, at least you would have something documented. You need to discuss the risks and benefits that include an explanation of, here's your diagnosis, this is the treatment plan, including the medications, here's what I expect, including realistic expectations for pain relief, not just I'm generally going to give this and hopefully it's going to work. Therapies in addition to drug therapy, like physical therapy, those things that might assist the patient that are outside of the medications. What side effects, obviously, and how you're going to manage them if they occur, and adverse effects, such as addiction, tolerance, withdrawal, and then the potential for impairment of judgment and motor skills. In other words, if somebody's going to be driving a vehicle or operating heavy machinery, you need to make sure you go through all of those things with the patient. All right. If the treatment plan includes extended drug therapy, you have to have a written pain management agreement. And that needs to include what labs are you going to do? You might tell the patient about limiting the number and frequency of prescription refills. You're not going to just keep writing them. Only one primary pain management physician should be prescribing these drugs. Again, like I said, you don't want to have multiple providers giving the same medications. Only one pharmacy. That way that pharmacy can monitor what the patient is getting as well. You need to explain what might get you to stop the drug therapy. In other words, if they start not using their drugs as you had prescribed, that's one reason. Or if they get a dirty urine sample, then you're going to stop the drug therapy that you've started. You also have to have a periodic review of that treatment plan. Like I said, they don't want you just to continue the medications forever. You must see the patient at reasonable intervals. Periodic review must assess the progress toward the objectives. Are they getting better? Do you need to change the medications? Those are all things that are really important about the treatment plan. Each periodic visit obviously should be documented. Contemporaneous to the periodic reviews, you have to adjust or document any adjustments in your plan. If the patient needs more pain medication, you need to explain why they do and obviously write the increase. If their pain is controlled, then you might consider reducing the pain medications as well. You must base any continuation or modification for those drugs on an evaluation of their progress toward the treatment objectives. That sounds obvious, but again, they don't want you just to continue something without evaluating. You have to document the progress or the lack of progress and the satisfactory or unsatisfactory response to treatment. Did they have decreased pain? Did they have an increased level of function, or did their quality of life improve? Now, physicians have to base any continuation for pain based upon the evaluation of those towards progress. Document that progress. I think we've already gone through most of those. Did I hit the wrong one? Here we go. You need to have objective evidence of improved or diminished function. That has to be monitored. You need to speak to family members, caregivers, anybody who's in and around. I'm sure you've had patients who have said they're doing great, but if you talk to family members, they say they're obtunded, they stay in bed all day, they really aren't doing what they used to do. So you need to talk to other people to make sure that the medications you're giving are actually doing something good for the patient. If the patient's progress is unsatisfactory, you have to assess the patient again and say, what are we going to do, or how are we going to change our treatment plan? You must periodic review patient compliance as well, because you don't want a patient to divert their medications, or you don't want somebody to become abusing their medications. Review the PMP and consider getting a tox screen just to make sure. Obviously, if they don't have drugs in their system and you have given them drugs, then you know they're diverting. They're not taking their drugs. And if you find drugs that you didn't know were in their system, then you need to sit down with them and find out who else is prescribing pain medications. If you determine a step isn't necessary, such as getting a tox screen, if you see something that's a red flag and you don't get a tox screen, you need to record why you didn't do that. My recommendation would be to go ahead and do a drug screen periodically just to make sure. Trust but verify. Referrals and consultations. consultations, you must refer out if the patient is over your head. You ought to consider referring patients who are at risk for abuse or addiction, patients with other problems, substance abuse history, psychiatric disorders require even more care, bipolar patients. Consult with or send out to a referral management of such patients, because if it's over your comfort level, you definitely need to send them out to somebody else. All right, medical records. I'm going to race through this because everybody knows what medical records should include. H&P, labs, consults, treatment objectives, R&Bs, informed consent, treatments, prescriptions, obviously all the parameters of giving a prescription, and instructions and agreements about those medications. Periodic review as well, we've already gone over. All right, opioid antagonist. You can have a standing order to provide an opioid antagonist, Narcan. Any patient who has an opioid medication that is at risk. Obviously, any patient who's at risk for experiencing a drug overdose based on prescriptions from other providers. You can give it to a family member, friend, or anybody who's in a position to assist. The law has become very open for that. Persons at risk include people who are prescribed opioids, people who are receiving a rotating opioid medication regimen and thus are at risk for an incomplete cross tolerance, people who have a history of intoxication or overdose, or people with a legitimate need coupled with a suspected or confirmed history of substance abuse. In other words, people who have abused before still do need pain medication, but those people may be at a higher risk of overdose, so go ahead and give an opioid antagonist. All right. They also found that people on extended release may have an increased risk for opioid overdose. You're usually supposed to start not extended release. That's the best way to do it. People who have ever been through a detox program, those people should be given Narcan as well. People who recently are released from prison that have a history of opioid use, those too should be given Narcan. People resuming opioid therapy after an interruption, and people who use illicit drugs. Like I said, drug abusers do have pain and they do need to be on opioids, but you have to watch them extra special. All right. There's also some good things that they put in the law. So anybody who basically gives an opioid antagonist is not going to be responsible or liable for prescribing or failing to prescribe it, but my recommendation would be to prescribe it. And you're not going to be liable for any outcome resulting from the eventual administration of that opioid antagonist. Next, we've actually codified, we put in the law prescription limits, and they have a number of different, categories for what the pain is. What kind of pain do we have? Acute pain, they have defined that as normal predicted physiological response to a stimulus, such as their disease process or surgery. Acute pain is not chronic pain, or pain being treated for cancer, hospice, end of life, or other palliative care. Acute pain is normal and what we expect.
When it comes to prescribing opioids, is it true that all pain is not the same?
Yes, and as I started, acute pain, they have actually codified it in the rules that it is no more than 30 days. That's what they're considering acute pain. And then I'm going to go through the rules where they discuss acute pain, chronic pain, and post-surgical pain. So acute pain is less than 30 days. Chronic pain is over 91 days. And then they have this middle category of post-surgical, post-procedure, persistent non-chronic pain. And that's the pain that's between 31 days and 90 days. But that's how the statute has defined these things. So for the treatment of acute pain, practitioners cannot issue a prescription that exceeds 10 days or provide for a refill. They don't want you to give that opioid for too long if it's just acute pain, if it's just started. But the caveat is a patient can come in every 10 days and get another prescription because it doesn't limit the number of times that can happen. The 10-day rule does not apply to chronic or the post-surgical pain, only to acute pain. So when you have somebody coming in for the first time, you can only write them a prescription for 10 days, not more than the 10 days. The rule does not apply to a prescription for an opioid for the treatment of substance addiction, and you're not going to be subject to criminal penalties or civil penalties for refusing to dispense a controlled substance that exceeds that limit. Now, let's talk about COVID rules quickly about telemedicine. Hopefully these rules will necessarily come to an end in the next few months, maybe this fall, the end of this year. But you can see a patient and give them opioid medication with telemedicine if they're an established patient, if they're seeking a telephone refill of an existing prescription, and you determine that a telemedicine visit is appropriate. In other words, they don't want you treating a new patient, and they don't want you treating a patient that you've seen that isn't already on an opioid via telemedicine. You probably need to bring them in. If the patient is treated for chronic pain with scheduled drugs through telemedicine, you got to document that in the medical record. Things you ought to consider when you're deciding whether you bring them into the office or you can do it via telemedicine is, when's the last time you saw them? What are the problems do they have? And do they have any occupational related COVID risks? These aren't the sole things, but these are the things that I want you to consider when you decide whether you're going to bring somebody into the office or just try to do it via telemedicine. All right. Treatment for acute pain with scheduled drugs through telemedicine is allowed, and I'm just going to highlight down here, it still goes through May the 1st. The governor keeps extending it 60 days at a time. Eventually this will end, but at least until May the 1st, you can use these telemedicine visits to prescribe these pain medications. All right, quickly I'm going to go through prescribing for yourself or family members. You basically have to consider yourself or family member a patient. You have to have an adequate H&P, create a medical record, and you can't prescribe for more than 72 hours. It's considered immediate need. I'm not going to go through the client that I had who lost his license, but basically he had prescribed his father a controlled substance. He ended up taking the controlled substance, and he had already been under a program for drug abuse, and he ended up losing his license because of it. So don't let that happen to you. All right. I'm going to race through these, Kathy. I know I'm past time. What should physicians know about limiting TMB complaints? Basically, I had somebody at TMLT look all the complaints up about who got in trouble for prescribing opioids. Well, nobody got in trouble for not prescribing opioids, but they did get in trouble with the TMB for prescribing opioids. It was usually over-prescribing, non-therapeutically prescribing, failing to identify high-risk patients, or failing to identify a drug seeker. So you can get in trouble for prescribing opioids, but nobody's ever gotten in trouble for not prescribing opioids at the TMB. All right, how do we avoid complaints? We follow the rules. We refer out to pain management. We refer patients to addiction counseling if you believe that they are addicted. Terminate the physician-patient relationship and give them 30 days if they're not following your orders. Do not keep patients like that. And document. Documentation is the most important thing. All right, DEA, I'm going to quickly run through there. Don't be scammed by a drug abuser. They actually have a pamphlet about how you can avoid getting scammed. This guy's lying, and if any of you can tell he's lying by that picture, you're better than I. Drug-seeking patients exhibit unusual behavior. They have demanding personalities sometimes. They have an unusual appearance. They have an unusual knowledge of the medications that they want, and they give a history of textbook symptoms. Why? Because they want the drug. And they give evasive answers regarding their medical history. They're as vague as they possibly can be so that you don't check up on them. This guy's the same guy, and he's not lying. These drug seekers are reluctant to give information regarding prior treaters because if you call a prior treater, they will tell you that they had a problem with this patient. So try to get prior treater information. They ask for a specific drug by name because that's the one that they like. They exaggerate their symptoms. They request to be seen right away or at the end of the day or after hours so that you're rushed. They claim to be out of town or from out of town. They feign symptoms. They state that no other drug will help me besides this one specific drug in this specific quantity and amount. They say that their prescriptions have been stolen and they request refills more often than prescribed. Please don't be fooled by these folks. Any of these behaviors are a red flag. You ought to share this with your office staff. If patients exhibit these behaviors, you need to proceed with extreme caution. You need to spend a little extra time so that tragic consequences don't result. All right. DEA actually, they offer advice about how to do this. You can request that the patient provide picture identification. Y'all are doing that probably for insurance information, but if you get a picture ID, you can confirm it's the right person. Call prior treaters, like I mentioned, if you can, to see what kind of relationship they had. Conduct a thorough exam no matter how they try to rush you through it. Don't let them do it. Document the exam to support a diagnosis and treatment, and if you prescribe a controlled substance, make it for a very limited quantity. Don't take their word for it. Don't give them the medication just to get rid of them. Don't prescribe outside of your scope of practice because plenty of people get in trouble at the medical board if they continue medications that really should be continued by another physician, but they felt that they could do it themselves. Stay within your specialty. And I had a case of a drug seeker. I will just tell this story in less than 10 seconds. Basically, a patient went to the hospital. She was a drug seeker. She literally exchanged sex for drugs in the hospital. People will do just about anything that they have to get medications if they're addicted to drugs. I'm not sure if any of y'all have seen that strange of a situation, but I'm sure you've seen some patients. All right. Another option is to refer the patient to a pain management specialist so they can be more closely monitored. If they don't follow through with the consult, consider terminating the physician-patient relationship. You do not have to continue seeing people that don't follow your orders or that are overly complex and need to be seen by somebody else. Here's the DEA site. They actually, if you go to their website, they have a place for you to report people. There's all sorts of things you can report. Patient selling drugs if you think, suspicious doctors, illegal drug trafficking. You can click on all of these things so that it becomes on the DEA's radar and they can take a look at it. You can report all of these things. There's the website for it. If you download the presentation, you'll have it there. And I am over time, but I'm going to summarize. Yes, the opioid epidemic is real. You can help correct the situation by being judicious in prescribing. You shouldn't consider opioids first-line treatment for pain. They should be used sparingly in conjunction with physical therapy and those kinds of things. And always be alert for manipulative behaviors and know how to respond to those drug-seeking patients. So you need to train your staff as well. Let me see if I can go through some of the questions.
Brett, thank you for that great presentation. Just a couple of things before people start jumping off. I hope you can stay on for the questions, but we would appreciate your feedback. Please either fill out the CME evaluation that is opening in your browser now, or click on the click here on your screen and open the browser, the CME evaluation in your browser. So do you want to take off on or check on the questions, Brett?
I'm going to try to run through just a few of these. I don't want to get into the very, very specific ones because they probably relate to just one person. Talking about checking the PMP, yes, just a statement that you checked it should be sufficient in your records. Quite frankly, like I said, the TMB can have access to the PMP, so they're going to know if you checked, even if you didn't document it in your records. You're supposed to document but they know anyway. So just a quick note that you did do it. Yes, I do believe staff can get their own accounts. I think you have to go to their website to get those people, to get your staff on there. Now, the 555 list within a certain time frame, I don't know about the answer to that. I would assume it would be within the month, since that's when they're checking those things. Okay, and I didn't have the list. Tramadol is, codeine is one of those controlled substances as well. It has a lot less than fentanyl and morphine, obviously, but yes, you probably do need to check the PMP for those. How frequent should you see chronic pain patients in the clinic? That number is variable. It depends upon how long you've seen the patient, what their condition is. Obviously, the argument's going to be, if you ever have a problem with the TMB, did you see them frequently enough? And so seeing them when you renew their medications at a reasonably frequent time so that you can evaluate what their medical condition is. I know that's a vague answer, but it's not defined. And what happens if you start seeing some risks develop? Then you probably ought to see them more often for that period of time. So I'm sorry I can't give you an exact answer of how often you need to see patients, but it needs to be reasonable. Is 90 days reasonable? Probably. Is every 6 months reasonable? Maybe for some situations, but not all. And sometimes you probably ought to see them at least once a month, if not a couple of times a month when they're starting, or if they have any problems that you see might be related to addiction. Informed consent ought to be given for both chronic and acute. Even if you're starting somebody on a medication, you want to let them know, here's the things that you need to watch out for, even though you're only taking them for 10 days. Obviously, chronic, yes, you need to talk about all of those things. And we talked about hospice patients. Again, those patients are usually getting the medications from the nurse or the healthcare provider. And codeine, yes, is one of those drugs. Even though it has very little morphine equivalents, it is one of those drugs. Again, is it a telemedicine problem? If you haven't prescribed it before, the rule is that you're supposed to give it. Now, is that usually going to result in a problem? Probably not, because it would be pretty tough for somebody to take that much, but you're supposed to be giving them the informed consent about that as well, and you probably ought to bring them in. All right. Prescriptions about prescribing for self, is it controlled substances or all prescriptions? Technically, it should be for all prescriptions, but what are the ones you're going to get in trouble for? Those are going to be the pain medications. If you give somebody an antibiotic, I mean, unless they have some kind of reaction to it or they get C. diff or something like that, that's not usually going to be the problem. What they're really looking for is you prescribing one of the medications at the PMP, a benzo or an opioid. Okay. So in a hospice where they're not in a hospice and where they're getting medications from family members, then yes, that's something you may want to consider going ahead and getting the PMP. You just want to make sure that they're not diverting the drugs, because then you have family members that are in control of the drugs and not a healthcare provider. All right, CME problems. Yep, metabolite of codeine is morphine. All right, I know I've taken way too much of everybody's time today. Thanks you so much for watching. I do give this in 2 hours where I can actually talk about some of these things and give you some war stories. So get a hold of TMNT if you want me to give it to your group, because it is worth CME. I know that for 2 hours. All right, Kathy, anything else?
Just real quickly, there will be an award, or we will award a half an hour of CME for today. And you will get a recording of the webinar. The link will be emailed to you tomorrow. You should have I did post the link to the evaluation in the Q&A pod, so you can click on that as well. Thank you for joining us today. We hope to see you all next month, and If you did